Hey friends! In today's video, we're going to talk about sickle cell anemia. And if you like this video, make sure to give it a thumbs up and subscribe to my channel. Also, make sure to check out all the free resources I have for you down below, as well as the NCLEX study guide. But let's get into it. Okay, so sickle cell anemia. So it is a severe hemolytic anemia that results from inheritance of a sickle homoglobulin gene. Sickle cell anemia is the most severe form of sickle cell disease. So the pathophysiology of sickle cell anemia is exposure from the sickle cell hemoglobin acquires a crystal-like formation when exposed to low oxygen tension. A change in shape, so the oxygen level in venous blood can be low enough to cause the erythrocyte to lose its round, pliable disc shape. And then adherence, these long, rigid erythrocytes can adhere to the endothelium of small vessels. When they adhere to each other, blood flow to the region or the organ is reduced. And then reversion, if the erythrocyte is again exposed to inadequate amounts of oxygen before the membrane becomes too rigid, it can revert back to a normal shape. This is a chart. I really love these charts that show the pathophysiology because you can get a ton of information on one page, which makes it much easier to memorize. So this includes the pathophysiology, the mechanism, signs and symptoms, as well as lab findings and also complications. So if we look up at the top, we can see right here that there are the sickle cells. So those are like the long kind of half-mooned looking ones. And then we can see regular blood cells. So the red blood cell shape is cyclical due to the polymerization of the mutation of intracellular hemoglobin S. So pretty much this person, it's a hereditary disease. They get this gene from their parents and it causes their blood cells to have that cyclic shape, which is why it's called sickle cell, which then leads to vaso-occlusion. So the sickled red blood cells lodge in the small vessels and block blood flow to the organs and tissues, which then causes a blockage of venous outflow, which then a blockage of arteries with decreased oxygen of the organs and tissues, and then also occlusions of vessels in the lungs and increased pulmonary blood pressure, which then is going to lead to all these different signs and symptoms. So priapism is a symptom of sickle cell disease, splenic sequelae, so blood pools in the spleen, and causes hypotension and splenomegaly. There's also the blockage of arteries decreases oxygenation to organs and tissues. So this is going to cause infarction of bone, which causes pain. These patients have lots of pain. And if occluding in the hands, you'll see dactylitis. The vaso-occlusion of splenic arteries, again, back to that splenic infarction. This can cause red blood cells occlusion not removed by the spleen, which can then lead to Howell-Jolly bodies. So red blood cell DNA remnants on a blood smear. That's a lab finding. Then also it can lead to infections from encapsulated bacteria, which can lead to meningitis or sepsis. And vaso-occlusion of other arteries such as cranial, renal, and femoral can cause stroke, renal failure, aseptic necrosis of the femoral head. Then there can also be in sickle cell extravascular hemolysis. So that can lead to macrophages in the spleen and phagocytosis sickle cell red blood cells, which can lead to normocytic anemia. It can also lead to an increase in red blood cell breakdown, which causes unconjugated bilirubin release from red blood cell breakdown. So you'll see an increase in the level of unconjugated bilirubin in the blood, and some of it will deposit into the skin, so we'll see jaundice. Can also lead to an increase of conjugation of bilirubin in the liver, which releases into the bile and causes cholelithiasis. We can also see an increase in marrow erythropoiesis to compensate for hemolysis. So the patient's red blood cell level becomes dependent on increased marrow activity, which if it's suppressed by marrow infarction or viral infection, can lead to apoplectic crises, which is profound anemia. And red blood cell precursors are released into the bloodstream, which can cause reticulocytosis. And again, you'll see that on a peripheral blood smear with septal stain. Okay. So causes. This means what can increase the symptoms. So cold temperature, colds can aggravate the sickling process because vasoconstriction slows the blood flow. Also, tissue hypoxia, necrosis causes a type of sickle cell crisis called the sickle crisis. Human parvovirus, which can cause an apoplectic crisis, results from infection with the human parvovirus. And a splenic infarction, so sequestration crisis, results when other organs pool the sickle cells, just like the spleen. So again, all of this stuff was on this lovely diagram. And again, you can print that out. Just take a screenshot. So clinical manifestations of sickle cell anemia can also so it's always present. Usually hemoglobin values are 7 to 10. We'll see jaundice. Usually this can be seen in the eyes. We can see dysrhythmias and heart failure can occur in adults, and we may see enlargement of bones because the bone marrow expands in childhood in a compensatory effort to offset anemia, and sometimes leads to enlargement of bones of the face and the skull. We may also see complications such as infection because they're usually susceptible to infection, particularly pneumonia or osteomyelitis. They also might get a stroke due to the decrease in oxygen supply because of the sickling. A stroke may occur. Renal failure, so blood flow is reduced to other body tissues, including the kidneys, which may lead to renal failure. And heart failure, because the heart compensates for the decreased blood distribution by pumping more blood and can ultimately fail because it wears out. So different assessment and diagnostic findings we can look at when we are assessing these patients. So we can look at a CBC. We can look for reticulocytosis, where a count may vary from 30% to 50%. We can look at leukocytosis, especially in a vaso-occlusive crisis, with counts over 20,000 for white blood cells can indicate an infection. We can also sometimes see decreased hemoglobin from 5 to 10 in total red blood cells. We can see elevated platelets and a normal to elevated MCV. We can also look at stained red blood cell examination. So this will show the shape of the blood cells. So if they're sicular, we can also look at a sickle turbidity tube test, which is also called a sickle deck. This is a routine screening that determines the presence of hemoglobin S, but does not differ between sickle cell anemia and the trait. We can also look at hemoglobin electrophoresis, which identifies any abnormal hemoglobin types and differentiates between sickle cell trait and sickle cell anemia. Results may be inaccurate if the patient has received a blood transfusion in the past 3 to 4 months. We will usually see the ESR is elevated. We can look at erythrocyte fragility. We can look at ABGs, which may reflect a decreased PO2 if there's defects in gas exchange at the alveolar capillary level, or we could see acidosis if they're having hypoxemia and acidic states because of being in the vaso-occlusive crisis. We can look at serum bilirubin. Usually this will be elevated. We can look at acid phosphatase, which is usually elevated. Alkaline phosphatase is usually elevated during a vaso-occlusive crisis because of bone and liver damage. We can look at LDH, which is usually elevated. Serum potassium and uric acid are usually elevated during a vaso-occlusive crisis. We can look at serum iron, which may be elevated or normal. We can also look at total iron binding capacity, which is usually normal, sometimes decreased. We can look at urine and fecal urobilinogen, which is usually increased, which indicates red blood cell destruction. Intravenous pyelogram, which may be done to evaluate kidney damage. They may also do a bone radiographs, which can demonstrate skeletal changes, and they may use x-rays to indicate bone thinning or osteoporosis. So the medical management of patients with sickle cell anemia include peripheral blood stem transplant. So this can actually cure sickle cell anemia. However, it's only available to a small subset of affected patients because there's either lack of a compatible donor or because severe organ damage is contraindicated. There's also transfusion therapy. Long-term red blood cell transfusion therapy may be effective in preventing or managing complications. Supportive therapy such as adequate hydration is important during painful sickling episodes. Aspirin is really useful to diminish mild to moderate pain, and NSAIDs are useful for moderate pain and can be used in combination with opioid analgesics. We also want to monitor pulmonary function and pulmonary hypertension. If it should be treated early if found. Infections and acute chest syndrome with predisposed to crisis are treated promptly. We should be using incentive spirometer to prevent pulmonary complications, and they may also use a bronchoscopy to identify the source of pulmonary disease. So pharmacological therapy for these patients include hydroxyurea, which has been shown to be effective in increasing the fetal hemoglobin levels in patients. Also, arginine has anti-sickling properties and enhances the availability of nitric oxide, the most potent vasodilator, resulting in decreased pulmonary artery pressure. So our nursing assessment should include factors causing previous crises. We should identify the factors that precipitated previous crises in the patient and measure the patient uses to prevent and manage the crises. We should be assessing pain levels, and we should be using a pain intensity scale. We should be assessing the characteristics of the pain, the quality, frequency, and factors that aggravate or relieve the pain. We should be looking for signs of infection because they're susceptible to infection. Our nursing diagnoses, again, there could be a lot of different diagnoses. These are just some examples. So acute pain related to tissue hypoxia due to agglutination of sickle cell within blood vessels, risk for infection, risk for powerlessness related to illness-induced helplessness, and deficient knowledge regarding sickle cell crisis prevention. Our care plan and goals should include relief of pain, decreasing incidence of crises, enhanced sense of self-esteem and power, and an absence of complications. Our nursing interventions for sickle cell anemia. So the first is we should be managing pain. We should use the patient's subjective descriptions of pain and pain rating on a pain scale to guide the use of analgesic agents. And we should support and elevate any joint that is actively swollen until swelling diminishes. We should teach patients relaxation techniques, breathing exercises, and distraction to ease pain. When an acute painful episode has diminished, we should implement measures to preserve functioning, such as physical therapy or transcutaneous nerve stimulation. We should also be preventing and managing infections, so monitoring for signs and symptoms of infection, initiating prescribed antibiotics promptly, assessing patient for signs of dehydration, teaching patients to take prescribed oral medications at home. If indicated, we should emphasize the need for them to complete the entire course of antibiotic therapy. We should promote coping skills, so enhance pain management to promote a therapeutic relationship based on mutual trust. We should focus on the patient's strengths rather than deficits to enhance effective coping. We should provide opportunities for patient to make decisions about daily care and increase feelings of control. We should also increase patient knowledge, so teaching them about situations that can make sickle cell crises happen and steps to take to prevent or diminish such crises. If hydroxyurea is prescribed for a woman of childbearing age, we should inform her the drug can cause congenital harm to unborn children and advise about pregnancy prevention. We also want to monitor and manage for potential complications with sickle cell anemia. So we want to watch for leg ulcers. We want to protect the legs from trauma and contamination. We want to use aseptic technique to prevent infections, and we want to consult a wound nurse if available in our facility. There's also a side effect of a priapism, which can lead to impotence. We want to teach the patient to empty the bladder at the onset of an attack, exercise, and take warm baths. And we want to inform the patient to seek medical attention if an episode persists more than 3 hours. We also want to help patients with chronic pain as a big symptom of a sickle cell crisis. So we want to emphasize the importance of complying with prescribed treatment plan. We want to promote trust with the patient through adequate management of acute pain during episode of a crisis. We want to suggest to the patient that receiving care from a single provider over time is much more beneficial than receiving care from rotating physicians and staff in emergency departments. When a crisis arises, emergency department staff should contact the patient's primary healthcare provider for optimal management. We should promote a continuity of care. We also want to promote home and community care. So we want to involve the patient and his family in teaching about the disease, treatment, assessments, monitoring needs to detect complications. Also teach about vascular access device management. We also want to advise healthcare providers, patients, and families to communicate regularly, provide guidelines regarding when to seek urgent care, and provide follow-up care for patients with vascular access devices if necessary. Our evaluation could include things like, depending on the patient outcome, relief of pain, decreased incidence of crises, enhanced sense of self-esteem and power, and absence of complications. Discharge and home care, so vascular access management, a nurse in outpatient facility or a home care nurse may need to provide follow-up care for these patients. In communication, all healthcare providers who provide services to patients with sickle cell disease and their families need to communicate regularly with each other. And our documentation should include the client's description of response to pain, acceptable level of pain, prior medication use, signs and symptoms of the infectious process, plan of care, teaching plan, responses to interventions, teaching and actions performed, attainment of progress towards desired goals, and long-term needs. So that is the discussion on sickle cell disease. I hope you guys enjoyed this. I hope you found it helpful. If you did, make sure to subscribe to my channel and give this video a thumbs up, and definitely check out those resources down below. I have lots of free resources to help you study, as well as an NCLEX study guide. So until next time, bye.